And I shared my cell phone number because I shared in the live session that I'm more than happy to talk to anybody that's trying to get a team approved. And that's 501-231-4426, or you can always reach me through Aaron or the national office. Next slide. Okay, so an approved team the depends on a vision and a mission. Next slide. And the purposes are to basically show that a group of providers, a team, is experienced, qualified. They contain multiple disciplines. They provide coordinated and consistent care, and it's a voluntary process. So it's not something that the federal government, the state government, or anyone requires. Although there are some benefits that we'll go through later, potentially with some of these entities. Next slide. Okay, so why should you become an ACPA approved team? It improves quality outcomes, supports patient satisfaction, and it demonstrates a commitment to ongoing improvement, because that's one of the requirements for approval, increases institutional reputation, and supports insurance company requests for treatment. Next slide. So again, what are some of the benefits? Well, you get to list your team on the ACPA website, which is a major portal for potential patients or providers who wish to refer a patient, or as a patient find an approved team. You get to use the ACPA marketing and communication materials, including the approved little logo over there. You get a team table tent, which, according to Aaron, is something you can put up at the reception desk or whatever to indicate that your team is approved. And you get a packet of approval items. Next. So standards drive the process. Next. So the standards of the ACPA are what we use to determine whether a team is approved or not. As some of you may know, and some may not, the standards is an ongoing document in the ACPA. It's what we call a live document. So the standards are constantly being updated. Whenever they get updated, then we update the approval process to comply with those standards. Those standards determine the team composition, management responsibilities, communication, cultural competence, psychological and social service issues, and concerns and outcomes assessments. Next. So the parameters of care, as I mentioned, are based off the ACPA's parameters of care. Those were last updated last year in 2024. And those are driven by evidence-based research. So these aren't just somebody's opinions. We use research to actually develop the framework for care delivery, which ACPA considers necessary for approval. So we recommend that you review the parameters of care. The website's there. Again, Aaron can provide any of these materials. Next. So the Commission on Approval of Teams, of which I'm currently chair, reviews all applications for new and renewing teams. We oversee the team approval process, and then we recognize the approved teams. Next. So we're going to go over the approval application process next. So guidelines, you need to refer to the standards for approval. Be sure all responses are in English, okay, with proper grammar and spelling, and use patient first language. If you're not familiar with what that is, rather than saying a cleft child, you want to say a child with or that has a cleft. So patient goes first, just like you wouldn't say you were a cleft orthodontist, you'd say you're an orthodontist that treats cleft craniofacial patients. Only completed applications will be accepted and reviewed. Essays are limited to a maximum of 500 words. Next. I want to stress that the application should be a team effort. This isn't just meant to be one single person completing this, okay? Just like we don't see patients all by ourselves, the approval and application process needs to be a team effort also. Obviously, the team coordinator and team leader are going to be involved, and the core specialties, and all of those individuals at a minimum need to review the application before it's submitted. One of the processes is those individuals basically have to sign off that they have reviewed this document and approve of its submission. We recommend that you download a copy of the entire submission and you keep it on file in case anything happens to it in the application process. Go ahead, Aaron. Does anyone have any questions? I don't see any way here to answer those, but if anyone's interested, raise your hands or whatever, and Aaron will let me know and I'll try to address those. Otherwise, there'll be some time at the end to address those. So regarding the medical records that you submit, which is a requirement, they need to be current within 3 years. They need to comply with HIPAA regulations. You need to omit all patient identifying information. If there are any that have PHI that is not redacted, that will be returned. If it's returned a second time, there will be an additional cost because of the additional cost to ACPA of dealing with that. Only submit the pertinent medical record pages, but remember, if you redact all the information, for instance, concerning a patient's age, date of birth, etc., you need to indicate in there without using PHI what the approximate age of the patient is, etc. Next. So you can start the application by going to the ACPA website. It's not too hard to find. If you already have an account, log in. Otherwise, create a new account. Aaron's very helpful at providing you assistance with that if you have trouble. You want to be sure that you use the team's full name, okay? Because if it gets approved, that's what the name that's going to be associated with it. Next. So team information, team listing. If you don't know or don't have a team ID, you can contact Aaron. One will be provided. There's actually three different types of teams that are recognized, and there's sort of a different application for each. There's a lot of crossover, but you can apply as a cleft palate team only, a craniofacial team, which doesn't necessarily include cleft. And then teams that treat both types of patients, those are cross-specialty teams. And there are certain requirements for each of those. So be sure to select the correct option for the type of approval that you're applying for. That response is going to affect the rest of the application. It is possible to be approved even though you submit as, for instance, a cross-specialty team if your application meets all the requirements for either cleft alone or craniofacial alone and not the other. You may receive an approval for that type of a team rather than a cross-specialty. The team listing information, if approved, that will be used for the team's public listing on the ACPA website. Next. Okay, lead team members. As shown here, I mean, these are the requirements for the approval. You have to have a designated patient care coordinator, and their functions are listed here. That team coordinator doesn't have to be one person. It can be multiple people, and we've certainly seen and approved applications in that situation. If it is more than one person, please clearly delineate which person does what functions. And you want to describe in detail those roles and how they ensure coordinated care. Next. The team leader director, again, this can be more than one person. They need to be listed as leaders or directors for the whole team. The craniofacial team lead, in addition, must be a surgeon trained in transcranial craniomaxillofacial surgery. And those requirements are in the approval application, and you need to make sure that those get submitted. Next. So the core team members, there are at a minimum, to be a team, you have to have a surgeon, a speech language pathologist, and an orthodontist. You have to have access to certain other individuals. Those are listed in the approval, but you have to have those three core individuals. They cannot be referrals. They have to be team members and participate and act as team members. So you also have to demonstrate access to professionals in the disciplines of psychology, social work, audiology, genetics, dentistry, otolaryngology, and pediatrics primary care. Let me stress, there needs to be an individual, a person that the team has access to for those services. If you refer to, for instance, the Department of Oral Maxillofacial Surgery for XYZ procedures, you can't just list, we refer to the department of. You need to have an individual in that department that's willing to be responsible and make sure those patients get seen and care gets provided. And that person's name is what we need on the application. Okay. They need to be entered in the appropriate category, and you must indicate whether they're a regular team member or a referral. And there's requirements for regular team members we'll go through later. Okay, Aaron. Team evaluation. That's the patient-facing component of the team's process. There's no one single evaluation that we consider as being approvable. Lots of teams do it lots of different ways. I've been on multiple teams that do it different ways. That's acceptable. But what we want you to do is describe that process, actual face-to-face evaluations by the disciplines represented on the team. Then question number 9, do they have the opportunity to receive same-day face-to-face evaluation by all core team members? Again, speech language pathologist, surgeon, and orthodontist. Notice there's a yes and a no, so it's not an absolute requirement that a patient see all 3 of these core team members. But if that is not the case, then as mentioned below, you have to explain how the results of the patient evaluation by whichever individual of the core team they do not see on that same day is involved in the decision-making process, not just logged into the team notes, etc., but how that person is actually involved in the decision-making. So you have to describe the logistics for how patients are seen by each specialist. For instance, patients rotate, or I've been in teams where the specialists are in rooms and the patients rotate. There's not a one way is the only approved way, but you need to describe that process. Next, team meetings. You have to have a mechanism for regular meetings among the core team members. Again, speech language, orthodontist, and surgeon. Okay. And why? To provide coordinated care and collaboration on that care for the patient. Okay. The most common issue with the previous standard and this standard is with the orthodontist that's listed on the team. They are most commonly the team member that is not involved potentially at the same place, same time, etc., that all the other specialists see the patient. But that orthodontist has to be involved in the team meeting, and their input has to be provided in order to coordinate and collaborate care, including with that individual. Okay, so again, are they held on the same day as patient evaluation? Again, there's a yes or no. Again, if the orthodontist never sees the patients on the same day, then technically you can't say yes here, because that is a core team member. And unless you have those 3 individuals involved in a meeting, it's not a team meeting. You can have all the meetings your team wishes, but it's, as far as ACPA is concerned, it's not a team meeting without those 3 core specialists involved. So again, no, you need to describe that, and don't go over the 500-word limit, but that needs to be described in detail. Otherwise, your application is going to be sent back, and we're going to say, you need to clarify this. Okay. All right. Next. In what format are they held? Again, there isn't one size fits all. We recognize that, but if it's none of the above, then again, I would go into great detail and explain how the team ensures that all patients are discussed collaboratively among, at minimum, the core team members, surgeon, speech language pathologist, and orthodontist. The referrals, etc., that input, etc., can come in at other times and other ways. You need to describe that, but you need to answer that question about the core team members, okay? Describe the process used. If a core team member, again, surgeon, speech language pathologist, and orthodontist cannot attend a team meeting, and we get applications that say if those three individuals can't be there, we don't have a meeting. It gets canceled, postponed, etc. If that's truly what your team does, then that's what you need to put in that answer and make it clear. If that's not the case, then we need to know in detail how all those specialists get input for that team's decisions for that patient that particular specialist missed. You need to describe how the results are recorded and become a part of the patient's team report. Next. Oops. Okay. Did somebody, I see somebody in chat. Sorry. Oh, that was just that it's going to be recorded. Okay. So team reports, again, it depends on what type of team application you're sending in, whether it's cleft palate, craniofacial, or both. If it's cleft palate only, then you just need to submit one report on a cleft palate patient. Make sure the diagnosis is clear, okay? And that, again, all three of those core specialists are involved in that meeting. If it's a 2-year-old and your team, for whatever reason, doesn't have the orthodontist see those patients at 2, that's not technically a team meeting, and don't submit that note. You know, it's kind of like when we all applied to dental school, medical school, speech language, whatever. We didn't choose somebody that was going to write us a bad referral letter to write us a referral letter. Okay. Pick out a letter that meets these requirements. And it seems like, you know, simple, but you'd be amazed how many letters we get that don't meet these requirements. So please make sure those 3 core specialists are involved. Okay. We need their name, their note, their recommendations. Okay. If you're applying for a craniofacial team, then we need a patient that not only has input from those 3 core team specialists, but they have to meet a craniofacial diagnosis. Okay. And we've listed some of those because, again, we would get notes that were for cleft patients that were seen by the craniofacial team, and they didn't have a craniofacial diagnosis as well. That is not appropriate. You can't do that. Okay. So don't do it. It'll get sent back and your approval will be delayed and you won't make friends among the commission. We're all volunteers. Nobody's paying me to speak to y'all, go through the applications or reviews. So please be cognizant of our time. Next. Okay, it must be a single document. You have to identify all these different things, the conditions, specialties, year of the evaluation. You can redact the month and day. Again, it has to document participation from the core specialties, anyone else who sees the patient, can be included in there, but we have to have those core specialists.
And I'm going to emphasize here that about where it says that the findings and recommendations need to be included. We see a lot of reports that come in that are missing this information, and a lot of applications get sent back for additional information because it's missing. So please make sure that information's in there too.
Right. So make sure that the diagnosis is on there. We've gotten notes that they redacted the diagnosis. That's not going to work. And as Aaron said, make sure that at the end there are recommendations. What are the recommendations for that patient at the end of that meeting? Okay. The year that it was generated and who generated the team report. Next. Referrals. You have to have a mechanism for referral and communication with other professionals, and we need you to describe that process. How you exchange information with schools, primary care professionals, outside agencies, etc. And then describe how the team facilitates transition from pediatric to adult care. Okay, there's different processes. Some teams see patients from 0 to 99 years. If your team does that, then that's all you have to put for number 18. Our team does not limit care to strictly pediatric patients. Okay, but if you do, if your institution, hospital, whatever, has a quote unquote cutoff, beyond which the team does not see these patients, then you need to be very clear on how the team helps facilitate that patient going from the care of individuals in the team to adult care. Next, reevaluation. We need to know when you reevaluate patients based on the team recommendations. So we need to describe the protocol for cleft patients and also the protocol for craniofacial patients. Next.
And I also just want to add here,
Okay.
we do have, I have seen in some applications and the commission's noticed where because these questions are very similar that sometimes teams will copy and paste between 19 and 20. But please note that those who are applying as a cross-specialty team, these are different questions. One is asking about cleft palate, and the other is asking for craniofacial diagnosis. So be sure that in the response it addresses each one.
Thanks, Aaron. So you have to have central and shared records. That's a requirement, okay? So do all team members have access to the same EMR and use it for patient documentation? There's a yes, no. But if you put no, and again, I'm going to pick on my specialty because that is the most common issue we see. The orthodontist doesn't, because oftentimes they're in private practice setting at a different institution, etc., which is okay to click no. But if you do, you need to describe who does not use it, how the team ensures that that specialist documentation is included in the team EMR, and how that specialist is able to view the team EMR if needed. That last part is what many teams don't mention. And it'll get sent back because you didn't mention how the orthodontist can view the team EMR if needed, especially when they may not see the patient on the same day. If they're actually the one treating the patient, they have to be able to access that team EMR. And in the live presentation, and I'll stress to y'all the same thing, it means something to be a team member. There are requirements, and this is one of the requirements. If, again, I'm going to pick on my specialty, orthodontist, if an orthodontist says they don't want to bother with whatever it takes to access the team EMR, the patient's EMR at their institution, then you need to find another orthodontist. Also, if the institution says, no, we can't allow that person to access our EMR, then someone on the team needs to go to that institutional individual and tell them, look, we're not asking for the sake of ease, whatever. This is a requirement for team approval, which we feel is very important, and we need you to grant this individual or individuals access. Okay. Describe how all the recommendations, including anybody that doesn't use the EMR, how those become part of the patient record when the patients are evaluated outside of the team setting. Again, pick on orthodontists. A lot of times we take our own records, x-rays, photographs, etc. Those need to become part of the team patient record, not kept solely in the orthodontist office. Again, I'm stressing this because it's a common area where teams get an approval sent back or denied. Next.
And before we go on to the next
Okay.
step, we do have one question that has come in.
Okay.
The question is, to confirm, all core team members don't have to be present for every in-person team visit with a patient, but needs to be involved in every team meeting. For example, is it okay for a patient to be seen by a craniofacial surgeon and speech orthodontist was not present for the same day, but was present for the team conversation later that day? Also, can the core team members attend the meeting virtually?
Yes. Was that a clear answer? The orthodontist can attend virtually as long as, again, they they have access, just like we do right now through Zoom. They can see the records, everything that's presented by all the other team members, and the team members can see and access whatever the orthodontist has. Okay.
And I don't see any other questions, so we'll move on.
Okay. Thank you. Okay. Communication. You have to provide appropriate information to the patient and the family caregiver about the evaluation and treatment procedures. And the team has to do this orally and in writing. And again, we get a number of applications that go into great detail on one or the other and then don't mention the other. So don't do that, okay? You have to do both, and we need you to describe how you do both. And indicate who's responsible for providing that information, and as I said, how it's communicated. Next. Patient family participation. Again, the team is supposed to encourage patient and family caregiver participation. You need to describe how their beliefs, values, and preferences are incorporated into the decision-making process and provide examples, and describe how the patient is involved at an age-appropriate manner in this decision-making process, and assent for treatment, and provide examples. Next.
Yep. And for these questions, I think it's good to just emphasize that that you provide examples. We do see some applications where basically we'll get an answer that's just restating the question, saying the team makes sure to consider the family and caregivers' beliefs and values and preferences are incorporated. Well, we don't need a restatement of the question. We want to have an actual example of how that's done.
Yep. Next. Okay, financial assistance. The team needs to assist families, caregivers in locating resources for financial assistance. Okay. So again, the question, you need to describe how you do that, and provide examples of that is great, but that has to be something that's included. Next. Cultural competence. This is covered through just about every accredited institution I've ever been associated with. And so a lot of teams just simply submit the information from their institution that relates to these things. But we need that, and how the team communicates both orally and in writing. If the patient, family, caregiver does not have English as their primary language, or English isn't the team's primary language. We've had teams from other areas where that English isn't their primary language. How does a team ensure that it's sensitive to ethnic and cultural diversity? Again, sorry, most institutions have policies, et cetera, for this, training, et cetera, that's required. I know I certainly get a lot of inboxes, notices every year that, you know, this training has to be completed, et cetera. So you want to indicate those. Next. Patient rights. Again, this is standard in a lot of institutions. You know, the patient's bill of rights, et cetera. You just need to provide that for the application. Next. Emotional behavioral. You have to have a mechanism to both initially and periodically assess and treat as appropriate the psychological and social needs of the patients and the family's caregivers, and how you refer for further treatment as necessary. So question 31, which team members are responsible for identifying those issues? Don't put the entire team does this. You're going to get sent that back and say that's not appropriate. We need exactly which team members are responsible for doing this job. Okay. We get it that if any of the team members discover an issue that isn't brought up, they're going to provide input, but somebody or some buddies on that team have to be responsible for identifying those patients, and someone has to be responsible for referring them if they need further evaluation and treatment. Okay. So 32, do you have a regular team member that's qualified to evaluate and treat them, or is it a referral? It can be either. You just have to explain. And especially if it's neither, you definitely need to explain that one. Next. Cognitive development. Notice that's not this, that's a different standard from the previous one. So don't just cut and paste, as Aaron says, the answers from above to below. And again, don't put the whole team for 33, we need to know which team member or members are the ones responsible for identifying and referring those patients, okay? And what process those individuals use to identify those issues. Again, is this a regular team member that's qualified to treat them? Referral, neither. Definitely explain. And then you need to describe in 35 how those patients with cognitive development issues are monitored over time to make sure they get the appropriate services. Next. Okay, so you have to conduct formal assessments of cognitive functioning when deemed necessary. And that's for for craniofacial and cross-specialty teams only. If you're a cleft only team, this is not a requirement. Okay, but if you're craniofacial only or cross-specialty, you need to provide this process. And what, for instance, psychometric testing your team does, etc., and then how those patients who are identified get referred, treated, etc. Next. Okay, outcomes assessment. And please realize that the commission is made up of lots of individuals, um, and we have volunteers in every area, okay? So, you know, your answer for cognitive development, a person reviewing your application in that area is the one that if there are any questions about it, the commission's going to refer to that person and say, okay, what do you think of this answer? Okay. I mean, I see some answers sometimes on things like that. I'm like, well, wow. Okay. I don't really know if that's um, acceptable or not, but I do know who on the commission can make that determination, and that person uh, will review the answer and reply. Okay. So please don't think that, you know, an orthodontist or a plastic surgeon is or speech language pathologist are the only ones that look at some of these questions and say, "What? No, they can't do that." Okay. Um, it's required if you're going to be an approved team that you self-monitor your effectiveness, and we want to ensure that you continually improve your outcomes. Team meetings alone don't count, okay? So we get a lot of applications. Oh, at every team meeting, we review da 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 da, and you know, we recommend this or that. That's not an acceptable answer. Okay, your application will be sent back, and or if you persist in that answer, denied. Okay, so don't do that. Okay. Um, and again, does the team, not individual practitioners, have a formal process to routinely evaluate its effectiveness outcomes? And yes or no? Yes, you need to describe the process. If you put no, doesn't mean you're going to be denied, but if there isn't one, notice in 38, you need to describe the plans for implementing one and include a timeline for implementation within 12 months. So not 3 years, 10 years. It has to be, that timeline needs to be within 12 months. And when you're up for renewal, expect that that will be one of the things that we will look at. Okay, next. We need an example of how the team has collected and used data to change team processes. Okay. The example may be a result. It could be a published paper. We have a lot of people who do that. It could be a grant application to further continue examining it, etc. If it is published manuscript, a progress report, representation, or presentation, you're welcome to attach that. And then the quality management system for patient family satisfaction, again, include an example of how that information was used to improve patient family satisfaction with the team or team process. Again, not just the surgeon or just the orthodontist, but the team. Okay, next. Team leader, director signature. Understand that when you sign this, you're signing that you reviewed it, okay? The team leader should read the application in its entirety before signing. We had a team recently that got denied because there was an issue with the application, and the team leader, I'm sure without realizing what they were doing, and I think as an excuse as to why the application got turned in that way, they admitted they had not read the application entirely before it had been submitted. Needless to say, it got denied and raised a lot of issues. So don't do that. I know if you're the team leader, you're really, really busy, but if you want to do this, do it right. Okay. Again, we get lots of applications. We're all volunteers. Don't waste our time. And this is one, that particular application was one example that the commission was very distraught with that individual that admitted they didn't review the whole thing before it got submitted. So don't do that. Next. There's a new section, fairly new, verification of core team members. So the surgeon, speech language pathologist, and orthodontist need to sign the application. Okay. That's to verify that they serve as a regular member of the team, and all information in the application, especially pertaining to their specialty, is accurate. Okay. They need to be added as collaborators. Next. Okay, and then we need an authorized institutional officer that signs. Erin can probably talk a little bit more about this if there are any questions or if she wants to chime in.
Yep, so the AIO needs to be someone who has a fiduciary responsibility for the institution or practice. Often you'll see this will be the chief medical officer. It could also be the dean of a medical school or the owner of a practice. We do have two options. You can either add them as a collaborator within the application, have them digitally sign, or you can download, there's a form that you can download within the application, and you can have them sign that form and then re-upload it into the application. So you can choose to do whatever is easiest for you.
Okay, next. The application deadline's July 1st, so it's coming up. There's a non-refundable initial application fee of $375. If your team is approved, that counts as your first year listing fee. Payment can be via check or credit card. You can do that online. If it's by check, you can mail it to that address, and you can certainly put attention Erin if you wish. Next. So to maintain team approval, you need to complete self-audit reports. Next. That's an annual submission of the form. The team listing fee for next year is $250. This fee can change, so make sure you're providing the proper fee. You need to provide a standards compliance review, an update of team information if there are any processes, team members, etc., that have come and or gone. You need to provide that. If you need assistance with things, we want to hear about that so that we can hopefully help. It's a simpler process than an application, and it's only evaluated by the commission if there is either missing information or a potential issue is noted or brought up. It needs to be reviewed, i.e. read in entirety, and signed by the team leader and the team coordinator. Next. So the team approval timeline for 25-26, April, June. Right now, new or renewing teams need to complete the team approval application. Then July, October, the commission reviews those applications and votes on them. In November, the teams are notified of approval status or if more information is needed. January through February, we update the approved team listing on the website, and the approved teams receive toolkits. The self-audit report schedule is different, August to October. If you are currently an approved team, you need to complete that annual self-audit report. And then in late October, those reports and listing fees are due to the ACPA. And then in January, if there are any updates to the team listing, etc., those are put on the website and or the teams are notified of any issues in the self-audit reports. Next. Okay, so additional resources, review the manual, the standards, read-only sample application is available on the website. So please use that sample application in your process. And Erin, if you have any questions, issues, concerns, you're welcome to contact her. If you think it's something that would be better handled by myself, again, you can either go through Erin or I already gave you my personal cell phone number. Next. Okay, are there any questions?
And if you have any questions, please either enter them in the chat or in the Q&A. We'll just give a minute, see if anyone wants to type questions. As Kurt mentioned, if you have a question that comes up after today, please feel free to email me. I will do my best to answer. If I'm unable to answer the question, then I always send it to either Kurt or another member of the commission to answer, and so that we can get you the best response.
And there was a question about whether this is available.
Yeah, so it says, will these slides or presentation be available for review after we're done? This is being recorded, so we'll have the recording available. It might be a day or two from now that we have it online, but we'll make sure to post it online.
And Erin, they also recorded the one that we did in Palm Springs. Is that going to be available as well?
I believe that one will be available to anyone who registered for the meeting, either for the and attended in person or registered for the recorded session. So if you did register for the meeting, you didn't attend the actual study session, then you could access that. However, I will note, it's very similar presentation. So if you did not register, this webinar should be sufficient.
Yeah, just I wanted to add that Newper, the new incoming chair, was present in Palm Springs and gave half of the presentation. So it was a little easier for me. I could catch my breath. But if you didn't attend that meeting, you don't get to, I guess, see her. You'll just have to deal with just me. So thanks for your attention, and please look at the commission not as an adversary. Okay. We're not out to get you. Okay. We really, my goal is truly to approve every team that we possibly can. You know, I want to do everything I can to make sure you get approved. But we do have to be responsible to obviously the other teams and the patients, families, et cetera. And that's why we have, you know, the standards, and we may require further information. But please don't look at us as adversaries in an adversarial role. Okay. You know, my goal is to make sure your team can get approved if that's at all possible. So please approach it from that standpoint. Okay. All right. Thank you.